Measurement for quality can be a burden to healthcare providers, but it can also drive improvement. And sometimes it does both. But if the goals for improvement are big enough, some additional burden, I think, is something that all of us are going to be ready to live with. This is Tom Lee, editor in chief for NEJM Catalyst, and today we're talking with Lee Fleischer. He's the CMO and director for the Center for Clinical Standards and Quality for CMS. He's been a key leader in academic medicine and especially anesthesiology, and he still practices part-time at Penn. But now in his major role, he's helping lead the quality measurement agenda for the country, really, through helping lead CMS's quality measurement agenda. He's going to give us a look at the thinking today and for what lies directly ahead. Lee, what would you say are the most important goals right now for CMS in measurement, the problems you're trying to solve, and how you're going to try to solve them?
Thanks so much, Tom. It really is a pleasure and to talk to you about this. And the administrator just put out her pillars, and among the two key pillars in this area really is advancing health equity by addressing the health disparities that underlie our health system, and building on the Affordable Care Act and expanding access to high quality, affordable health coverage and care. So within that framework, I think it's really quite important to think about what are the levers and what are the levers we have in the Center for Clinical Standard and Quality to drive to that equitable, high value care, which I think is it's sort of at the top of the pyramid, high quality, best value, patient centered care. And what we've learned from the pandemic is a resilient system. At the lowest, sort of at the baseline level, is our conditions of participation, those minimum standards that we push out to ensure that all healthcare providers who are covered by Medicare, who are certified, provide that care. And I think we need to rethink how they should include equity, just like we included safety 2 decades ago. That it's important that governance look at equity, and we've asked a number of questions in our request for proposals, request for information about how they should change. We then, in my mind, really have 2 levers or 3 levers to actually improve quality to get to that highest level. One is the payment models, another is the quality improvement activities. But what I think is really important are those quality measures. So as we look at them, it's still going to be important, and we can talk more about safety later, but to include safety measures, to include equity measures, to look at how we can include social determinants of health assessment measures, and that those measures really have multiple purposes today. They're really important to as I said, address underlying disparities in advancing care. It's going to be important to allow providers to see what best care could be achieved, but also where they are on that continuum and drive them to do better. And importantly, it's that transparency to the public that as they go into a facility that's certified by Medicare, that they have an idea transparently of where that center, where that facility does with regard to providing that high quality care.
Well, there are some really interesting ideas woven through your comments there. And I think that one of the biggest is that from your perspective at CMS, safety, high value, equity, these goals are indistinguishable now from other dimensions of quality. Deviations in those areas are deviations from the way we want to deliver medicine, and I think that that's appropriate and exciting. Let's turn to safety first. Like, how are you thinking about measurement as a lever for improving safety?
Well, as I think most people are familiar, the patient safety indicators have always been a critical part of the CMS quality metric program. And things like hospital acquired infections, FAWS, venous air embolisms. It's part of the IOM, original Crossing the Quality Chasm 6 domains. And we saw improvements to where people were getting excited about really having a huge impact on safety. But what I think is really critical is the CDC published data showing that since 2015 to 2020 marked continuing improvement in the hospital acquired infections, but really reversed during the pandemic. And even if you take out the COVID patients, really reversed. And the same thing with falls and others that we're starting to analyze. So the question really is it the engineering solutions that we put in, or is it the culture? But no matter what, we need to continue to evaluate those safety indicators, make them transparent to the public, because 20 years after the publication of To Err Is Human, we're still seeing concerns within the healthcare system.
Well, let me throw out an analogy based upon your own personal career and tell me if this analogy works. I was thinking that earlier in your career, you lived through and helped work on improvement in safety of anesthesiology. I think a lot of younger people here don't realize that if you go back to like 1990, complication rates related to surgery were much higher back then. And in a decade or decade and a half, anesthesia became much, much safer by adopting high reliability approaches. And I feel like to a certain extent, you're pushing the same thing for the country now. You recognize that every patient you're starting from scratch. You need constant vigilance. With COVID, we have had a worsening of patient safety, and we've got to respond to it, learn from it, and get better, knowing that every single day you're trying to be highly reliable. Does that analogy from anesthesia to the country's healthcare issues, does that work for you?
I think in part it very much works for me, and in part I think there's the extension that I've challenged anesthesia for, and I might bring up, which is this shared accountability concept. But I agree that anesthesia and both of our work around ensuring that the patient is properly prepared for surgery and anesthesia have been critical to show marked improvements. And I think the key issue is this mixture of accountability and psychological safety that we can continue to learn from with each instance. And I think anesthesia has both engineered solutions, i.e., the checklist from our machines, to color coding, to having more of a standardized pre-op, to that leadership. I think the thing that I would like to push on with regard to measuring quality is anesthesia did a lot of work within anesthesia to make things better. And what's exciting now is we're working very closely with our surgical colleagues in a joint accountability model with the facilities we practice in to do better. So, for example, the geriatric surgery verification process that the American College of Surgeons came out with, or perioperative brain health, are all issues of quality that really cross multiple disciplines. So I think hopefully that gives you the analogy, and well as where I'm hoping we all will go to.
Well, let's turn to the other topic that is part of what this era is dominated by: advancing equity. So, how are you and your colleagues at CMS thinking of using measurement to advance equity in healthcare?
Thank you. Well, if we don't have equity, we really don't have quality, because if there's a population that has much worse quality then, and you don't have line of sight, then it may be mixed in the total group, and that poor quality could be washed out. So I think there's a couple different things that we're working through. One is the question of getting sufficient data on who are the people who we care for are, so that we ensure we can stratify and look at individuals, and we're starting with dual eligibility, but we hope soon to be able to give back quality measurements, at least confidentially, at some point by race, ethnicity, language uh, perspective. And then there are areas that we know there are intrinsic inequities, there are structural racism, and maternal mortality is one of those high priority areas that we know there are significant problems with. So that we will lean into developing metrics around that space, and hopefully working with our Medicaid colleagues and others to really improve the safety and quality of care for all women undergoing labor and delivery. And I think if we take that equity lens, everyone will actually, in the end, have better quality of care.
Well, let me ask one last question, which is related to something I mentioned in the introduction, which is that you still are practicing part time as a anesthesiologist, as a working clinician with seeing patients during this pandemic. How has that role formed your thinking about your management role, leadership role at CMS? Are they like two separate worlds, one's a vacation from the other, or do you link them? Have you learned things in one that informs how you function in the other?
You know, it's really been mutually beneficial to still practice. I mean, understanding the stress, the burdens that clinicians are under, what it's like to work for hours at a time in an N95 under my surgical mask, um, learning the support people need to acknowledge things has really tempered and helped me provide that insight to CMS as we make policy. And it also asks the question of what has helped me understand the value of leadership within the context of supporting these clinicians and getting to that more equitable place. The example I gave on equity and maternal mortality, as I thought about it, I had started to ask the question about labor epidurals and, you know, pain management. So it became very real about how we can use that measurement and how important it is to feed that data back to the clinician. Because I think bottom line is clinicians want to do the best thing for their patients. And therefore, understanding sort of the tools you need to give them, and I think quality measurement is one of those tools, if used properly, really will help drive better care in the United States.
Well, Lee, I'm so impressed that you're able to do all these different things and in different cities, I would note, Philadelphia and Washington. And we're lucky that you're doing it. And I think that these efforts that you described to extend how we think of quality and high reliability to equity as well as safety are very important for healthcare. And I think this is great leadership, and we look forward to tracking it and hearing more from you on how it's going. So thank you so much for sharing these thoughts and the roadmap with us today.
Thank you so much, Tom. And I urge anyone, you can find my email on the web. I value the input I get from all of my colleagues. So look forward to hearing to help us formulate best policy.